Okay, have you heard this rumor about UMS and Herb Lair podcast teaming up? It's like oil and water. One is vetted and the other's unfiltered. How could that happen? Hi, Herb Lair. I'm doing my podcast a little different this time. Um, I say that about every time I do it. I guess that's because I've been diagnosed with Parkinson's, and some people might call it delusional. Um, what I wanted to do this time was take a virtual visit to the UAMS library. Okay, here's a personal invite from Dr. Dahl, who heads up the Department of
My name is
Neurology at
Dr. Rohit
UMS.
Dahl. I'm a professor of neurology and a Parkinson specialist at the University of Arkansas for Medical Sciences. The topic of Parkinson's disease psychosis can be somewhat daunting. The discussion can be for my patients and their family members. The reason why we find this discussion to be important is because it is relatively common. As many as about one in 3 people with Parkinson's disease would develop some degree of psychosis, and the disability from Parkinson's-related psychosis may be more than from motor features that are associated with Parkinson's disease. It is related to worse overall outcomes. There's increased burden on the caregiver. There is an increased risk of being admitted to an assisted living facility or skilled nursing facility when people develop Parkinson's-related psychosis. There's also a greater risk of mortality, in part because of the underlying worsening of Parkinson's disease, in part because other medicines have to be removed or reduced, in part because medicines that we use to treat psychosis have their own risk of causing more morbidity and mortality. So it is a really important topic to understand for our patients and their caregivers. I also want to relay that treatments are available. Often when psychosis is mild, people don't ask about what are their options. And so recognition and management of the symptoms may be delayed, in part because it is a hard topic to talk about. Some of the features that we see in Parkinson's-related psychosis are very different from those of other psychotic illnesses. In Parkinson's disease, Parkinson's psychosis should start well after the initial diagnosis of Parkinson's. We're talking 5, 6, 10 years after the diagnosis. And usually after the person has been on medications for managing motor symptoms of Parkinson's for a while. If the start is early, especially if psychosis or seeing things, usually visual hallucinations, if it starts before medications are started, we should question the diagnosis. The features that are associated with Parkinson's psychosis include illusions, where people may mistake, usually visual illusions, where they may mistake an object for something different, something animate. For example, mistaking a mailbox for a dog, or looking out the house, the bushes in the backyard for a person hiding. There may be presence hallucinations. People may sense that there's a presence around them. Or passage hallucinations. They may see something out the corner of the eye, and when they look, there's really nothing there. Hallucinations in Parkinson's-related psychosis tend to primarily be visual, although they can be in other sensory modalities, like feeling things that are not there, tasting something odd or unusual, smelling something odd or unusual, or hearing. Delusions are where people have false but firm beliefs that, for example, somebody's trying to harm them, that there may be strangers living in the house, people around them are not who they say they are. The causes of Parkinson's are tied intrinsically to advancing Parkinson's disease itself, especially duration of 10 or more years, advancing age, both are risk factors for Parkinson's-related psychosis. One of the major risk factors is presence of cognitive impairment or dementia. If there's dementia, if it arises early, we need to consider other possibilities like Lewy body dementia instead of Parkinson's disease per se. Sleep impairment, including lack of sleep, insomnia, excessive sleepiness, fragmented sleep, REM behavior disorder, they may all increase the risk of hallucinations. There's a separate talk about sleep in Parkinson's, and I'd encourage you to listen to that again. One of our hypotheses is that there's intrusion of dream state, the imagery, what you would be seeing in a dream state into wakefulness, and that causes some of the visual hallucination features. There are several medicines that can worsen hallucinations. They include narcotics, sleep medicines, medicines for depression, anxiety medicines, and dopamine medicines, as you heard in the dopamine talks, and some of the non-dopamine Parkinson's medicines. They can all worsen, they can all contribute to psychosis. Also, if there are any metabolic or physical stressors, for example, if somebody's sick, if there's an infection, if somebody's in the hospital, or emotional stressors, sometimes all of these can increase the risk of psychosis. The way we treat psychosis is dependent on you bringing it to our attention, you letting us know that you're having issues with psychosis. So talk to your doctor if you're noticing the presence of hallucinations or illusions. The first step that we employ is to look for contributors. Are there medical illnesses? Is there bladder infection or chest infection? Are there any other metabolic abnormalities? Has there been a change in the environment? Is there an increase in stress? Is there issues with sleep that are present that might be causing these the emergence of psychosis? Strategies to avoid delirium, confused state, they are all important. Redirecting people, stimulating them during the daytime, making sure that they get a more peaceful night's rest at night, ensuring that they're not getting off in their sleep-wake cycles. Those are all important. Reducing medicines that act on the brain, for example, pain medicines, medicines that are sedating, or bladder medications, even though they're meant for bladder, they go into the brain and may increase the risk of psychosis, certain types of antidepressants, all of those. And then if that's not enough, reducing Parkinson's medicines, they all are means of attempting to reduce the psychosis. If these strategies alone don't help, we often add antipsychotics. Now, this is really important for you guys to remember as well, that starting antipsychotics is, it has to be done carefully, because many antipsychotics, they can worsen the underlying Parkinson's and can at times worsen it severely so. There are 3 antipsychotic medicines that we can use without Parkinson's worsening. Those are, the names of those are quetiapine, clozapine, and pimavanserin. And when you bring this up to your doctors, we often talk about what the pros and cons are. For example, clozapine requires monitoring of your blood levels on a weekly basis, so it's a hard to use drug. Pimavanserin, one of the newer medicines, because it's newer, is also much more expensive than the other medicines. So we would have to tailor your plan based on how severe the psychosis issues are and other factors that are important in the delivery of the appropriate treatment. We always emphasize maintaining sleep-wake routines, making sure you're exercising, that there is social and cognitive interaction during the daytime with caregivers, making sure you're hydrated, looking for infections, things like that are all an attempt to improve psychosis. In addition to the medicines that are available, we're working on newer medicines to be able to help treat psychosis. And that brings me up to this last slide. If you are interested in participating in research, sign up to be contacted for research. You can do that by scanning the QR code on the left-hand side of the screen. Also, to enroll for support services, support groups, and other services that we provide, mindfulness, yoga, the virtual Parkinson's disease education program, walks associated with Parkinson's disease, or the Parkinson's art program, please scan the QR code on the right-hand side to be able to sign up for those. And lastly, this is the entire team of movement disorders providers at the university. We appreciate your time and attention.
It's a digital library, but it has a lot of segments or little topics about Parkinson's. And I think it's going to be neat to see what each doctor has to say there. Some of it's going to be a little bit about just Parkinson's in general, and it's given by the head of the department as well as my doctor, Dr. Vermani, and they talk about different subjects, and I found some segments there that are really good. Some are about even about speech and other things that you can participate in, but also talking about non-motor type Parkinson's, which you don't hear as much about, and I wanted to include that. But I'm going to have some fun things on this trip. I'm going to take a swing by War Memorial Park, again virtual. Morning Mayhem on Buzz 1037 with David Basil had an interview there with Joe Klein. Of course, Joe Klein's a basketball player, not football. But the interview was supposed to be with Joe Klein, and he, I don't know, I maybe did 1 or 2 minutes out of the 20 minutes of the interview that I captured. But I think it's kind of funny because Joe Klein was given a position where you couldn't hear him. His mic was not very good. I've got a better mic. I think he needs to be on my podcast sometime. Okay, I want to show you what the UAMS library is all about, so I'll show you some interviews and clips from that.
Life of patients with Parkinson's disease and is associated with increased caregiver burden. Non-motor symptoms are features of Parkinson's disease not associated with movement difficulties. The non-motor symptoms are listed on this slide. Non-motor symptoms may precede the development of motor features, and as the disease progresses, non-motor symptoms, particularly cognitive and mood disorders, can impair quality of life more than motor features. Some of these non-motor symptoms can occur years before the onset of motor symptoms. These include impaired olfaction, constipation, erectile dysfunction, REM sleep behavior disorder, depression, and anxiety. During my 3 talks, we will discuss most of these symptoms listed on the slide. Some non-motor symptoms will be discussed by other presenters. For example, mood disorders, speech and swallowing problems, and vision difficulties. Gastrointestinal dysfunction is common in Parkinson's disease. These include constipation, nausea, swallowing difficulty, and drooling.
Okay, I'm not experiencing any of these, so I'll probably skip past some of this.
This is part 2 of a 3-part discussion on non-motor symptoms in patients with Parkinson's disease. Here we will discuss common sleep disorders. Sleep-related symptoms are reported by more than 75% of patients with Parkinson's disease. Disrupted sleep can have a negative impact on health, mood, and quality of life. The most common sleep issues in Parkinson's include difficulty falling and staying asleep, excessive daytime sleepiness, acting out your dreams, which is called REM behavior disorder or rapid eye movement sleep disorder, restless leg syndrome, difficulty turning over in bed due to decreased bed mobility, waking up frequently at night to go to the bathroom. For insomnia, we first need to determine the cause of poor sleep. We want to assess if your motor symptoms and or Parkinson medications are contributing to sleep trouble. Motor symptoms such as tremors, slowness, and stiffness at or around bedtime might interfere with sleep, and adjusting Parkinson medications may help. Other options for promoting sleep include maintaining a regular sleep schedule, exercising daily, avoiding naps and caffeine in the late afternoon, sleeping in a cool, dark place, do not read or watch TV in the bed, using satin sheets and pajamas to make bed mobility easier, minimize drinking liquids for 3 hours before bedtime to avoid frequent nighttime urination, and go into the bathroom immediately before retiring. In some cases, medications may be warranted. We may start with over-the-counter medications such as melatonin to promote sleep. If that fails, we may consider short use of sedatives or adding depression medications to assist with sleep onset and maintenance. Excessive daytime fatigue is a common problem in patients with Parkinson's that can be present in approximately 30 to 50% of patients. It may be due to poor underlying sleep at night or associated with dopaminergic medications. Certain medications, like dopamine agonists, and these include pramipexole, rotigotine, and ropinirole, can cause sudden sleep attacks. Consider making lifestyle changes to help with excessive daytime sleepiness. Suggestions include establishing good sleep hygiene, get exposure to adequate light during the day and darkness at night, avoiding sedentary activities during the day, get physical exercise program appropriate to your level of functioning. You should avoid driving if you're sleepy, especially if you're experiencing excessive daytime sleepiness. You might want to talk to your provider about decreasing medications if they are causing you excessive daytime fatigue or sleep attacks. When conservative measures fail, stimulant medications may be warranted. Sleep apnea can be seen in up to 40% of people with Parkinson's disease, and symptoms include loud snoring with respiratory pauses. These pauses can last up to or longer than 10 seconds, excessive daytime sleepiness during the day, and restless sleep. Obstructive sleep apnea is the most common form. Diagnosis is obtained by taking an appropriate history, but also obtaining a sleep study. If severe enough, CPAP machine may be prescribed. Restless leg syndrome is a condition that causes uncontrollable urge to move your legs. It typically happens in the evening or nighttime hours when you're sitting or lying down. Moving temporarily relieves the symptoms. Although common in patients with Parkinson's, assessing for secondary causes of new symptoms or worsening of previously stable symptoms may be warranted. Assessing for iron deficiency, new medications such as over-the-counter antihistamines or new depression medications is important, as these may exacerbate or cause restless leg syndrome. Adjusting Parkinson medications such as dopaminergic medicines like ropinirole, rotigotine, and pramipexole may be helpful. Other medications such as preparations of gabapentin or pregabalin may be beneficial. Rapid eye movement, or REM sleep, is a normal part of the sleep cycle. This is when patients or people will dream. Patients with REM behavior disorder lack the normal relaxation of muscles during their dreams and therefore will act them out. A person may kick or get out of bed unknowingly. Treatment may be necessary. It is important to remove dangerous items such as guns and knives. You may also consider patting the floor, using bed rails, removing nightstands, or bed partners may need to sleep in another room to prevent injury. Pharmacological management includes melatonin and clonazepam. This is the group at UAMS.
I think we could have some fun. But the reason for that is, instead of going to the game tonight, I have a planned trip to Corky's, and I'm hoping that Corky's will have a TV there that I can see some of the football game, because it is on ESPNU, and if I were to take out ESPNU on my, I guess, Infinity or Comcast, it would be an extra, I don't know, $10 a month, which I don't take ESPNU normally. I take all the other sports packages, so that's another funny thing. But with that interview, I saw Joe Klein looking at his watch occasionally. I think he was wondering when he was going to talk and when he was going to be off there. And as I noted, that within the 20 minutes time he heard David Basil talk and others talk, there was very little time for Joe Klein.
But yeah, Joe, for us who go back to those 80s and 70s, a lot of great memories here. A lot of great memories since we got through. And
Joe, you never played in Little Rock. Was it Pine Bluff?
No, we played.
Where'd y'all play?
We played
Barton? Did you really?
We would play. I know we would at least every year play 2 games here and 1 in Pine Bluff.
Is that right?
Yeah.
Oh, really?
A lot of times it was over Christmas break.
Very
good. Yeah.
So did you have that kind of mentality as far as bags go? Hey, we're going down this way to Little Rock and things like that. Was that something that played into it?
Coming down here. I mean, we were always mad because we were usually at basketball practice when you guys were playing down here, so we couldn't come. The school used to close up and come down here. I mean, everybody came down here.
Well, by the way, did you see? And Cal gets that. Cal wants to take his team to have practice in Hot Springs.
Right.
He gets it, and I think he understands marketing and exposure to the fans, and it's a lot easier to do when you got 15, 20 players versus 85. But still, nonetheless, he gets it. Did you see yesterday where Nolan stopped by practice or the day before? Did you see any of that?
No.
Yeah, he introduced Nolan and bragged on Nolan to the players, and then Nolan gave him some input. Which Josh, I don't know if we have any sound on that, but it was just it was really good. It just obviously, I love the fact that he gets it. That Cal's smart enough to go. He finally got coached to come speak to the kids.
Oh yeah. No, I mean, Cal's just like you said, the word is he gets it.
He gets it.
And he embraces, like I'm sure he did at Kentucky when he got there. He embraces a tradition, embraces the players that came before, the coaches who came before. I've heard him say very nice things about Coach Sutton, and so, I mean, not doing that, you're missing an opportunity to engage with fans and get fans' attention, older fans, and then it's just the right thing to do. I mean, it makes the former players and the former coaches and everything. It's very appreciated by those people.
I think him being a veteran coach is easier for him to just dive right in and know things like that, as opposed to a new coach who has to go around because people are wanting to see him, so he's not having to knock on the door and somebody say, can you come back later? They're going to let him right in and talk to him. I saw video of Terrion Burgess yesterday. This kid from Benton, 42 flat-footed, 42-inch.
It does have some relevance when you start thinking about a library, and you can go there and you're not being told a lot. You're able to look and listen, and so I think that's a similarity there. But it also gives you an idea of what can be done, and so I wanted to get that captured, and that's part of the podcast today. And it's really just taking a trip to the UAMS digital library virtually, but it pertains to Parkinson's and some of the experiences that I'm having, and you'll see videos that are vetted there, where my videos, as you probably noticed, are designed for people that are experiencing depression, maybe delusions, and maybe anxiety, but it's kind of unplugged. It's you won't say, well, this was really thoroughly vetted by some doctor, but it's my opinion. And I wanted to show how I've either progressed or how I've used podcasts to capture some of the things that's spoken about within the library itself. Maybe I'm more of an anecdotal evidence of what you can do and some of the things I've tried, and maybe some of the ways that can be improved. And I do have a person that I've worked with, it's a doctor of education, has done online videos and training that I think could be helpful in developing care for people. Most care now is more like babysitting, and I want it to be a much more thorough understanding of the patient. And she's developed questionnaires, and these are interactive questionnaires that they do live with a person and with a patient. So it's a little more involved than just somebody filling out a form. So there's more to that, and hopefully this all leads into what's coming up in the future with the the things that's happening within, the national plan to prevent or to, to end Parkinson's Act, and that hopefully we can be a part of that. As you can see, I'm getting a phone call. I don't know that it's important, so I'll just let that display, and it looks like Hot Springs, so it's probably a Medicare call, and I'll see that when I try to call back that it's not really a working number. So that, and I got some other things I want to show you that through Facebook that I'm exposed to. It's kind of a funny thing about a new thing that's out there, and I'll show you that it's kind of like a wheelchair, but it's designed where you can move around, and there's a I guess one of those things where they show you something at a low cost and they show you something at a higher cost. The old days of working in TV and appliance business, we might have called that bait and switch, but that's I don't think Facebook, they like to outlaw a lot of things. They're concerned about copyrights or something. When you refer to a song that's 30 or 40 year old, or a movie that's 20 or 30 year old that has no issues with copyrights other than the fact that it just draws attention to it.
Grass. I want to show everyone just how fun this is to use and how effortless and easy it is to use. So this is not a power wheelchair. This is not a power scooter. Instead, this takes the best features of both of those type of mobility products and packages it into one product that is portable, lightweight, and easy to use. So now I get to go not only from point A to point B in my house, I also get to go into my community because I have a mobility product that I can take with me. Lightweight, get it into the trunk of my car. Let me show you why there is nothing in the world like the Journey Zoomer. Here's some of the magic. Think of a power mobility product. Many of them are 150, 200, 250 pounds. You have to use a lift to get them into your car. How about with the Journey Zoomer, in 1 second, I have folded this product up.
Oh my gosh.
With one touch of a release cable and 50 pounds. Now, I'm not that strong a guy. 50 pounds, I can get this in the trunk of my car. Here's what's even better. I want people to be able to use their products in the community, right? Let's say you don't want to lift this up into the trunk of your car. Your trunk is full. We've made it so that it's less than 12 inches wide. You can fit this behind the front seat of your car. Truly amazing technology.
Wow.
Once you get your Zoomer delivered to you at home, it comes fully assembled. Out of the box, this is what it looks like. You unfold it with that release cable the way I just did. You sit down, you press the power on button, which I'm going to show you in a few seconds, and you just go. It's so intuitive and effortless. There's no learning curve. There's nothing to do. You just get to unlock your independence, your mobility, your freedom. You get to go back to the restaurants with your family. You get to go back to the supermarket and shopping with your spouse. I hear from so many people that that's what they want to get back to. How about parks? How many mobility products do you know that can not only take you indoors, but also, here's indoors maneuvering around a coffee table. Here's turning on a dime with a product that can also take you outside into a park where you can go on dirt, you can go on gravel, you can go up hills, you can go down hills, you can go on grass, mowed grass.
Okay, here it is for $39.99, and here it is for $69.98, and then there's one that probably works for $1,649.99. What I wanted to do this time was take a virtual visit to the UAMS library. It's a digital library, but it has a lot of segments or little topics about Parkinson's. And I think it's going to be neat to see what each doctor has to say there. Some of it's going to be a little bit about just Parkinson's in general, and it's given by the head of the department as well as my doctor, Dr. Vermani, and they talk about different subjects, and I found some segments there that are really good. Some are about even about speech and other things that you can participate in, but also talking about non-motor type Parkinson's, which you don't hear as much about, and I wanted to include that.
Hi, my name is Rachel Sloan, and I'm one of the nurse practitioners here with the University of Arkansas for Medical Sciences. You may have experienced doctor's visits in the past where you didn't understand everything that was going on, or you weren't able to get all the information you wanted from your doctor. In this video, we'll explain how to get most from your doctor's visit, such as what to do before the visit, what to bring with you, and what to expect during and after the visit. So before the visit, there are a couple things that you can do to prepare. First, you need to know what to expect. You can ask and call the clinic staff ahead of time to know where to park, know how long the appointment, the first visit might last, and know where to exactly go once you get to the building as well. Before the doctor's visit, it's important to also think about things that you need to talk about with them. It's also very helpful to write down the reason for your visit, a list of your questions or concerns. For example, do you have a new symptom you want to ask the doctor about? Are you concerned about how medical treatment or medicine affects your daily life? Most doctors prefer that you don't wait till the end of the visit to go over the things that you're most concerned about. So it is helpful to have 2 or 3 things to discuss ahead of time with them, to put them in order so that way you're able to discuss that early on with them and all of your questions are answered. Also, before you go to your appointment, it's important to make sure you fill out any paperwork that the clinic sends you as well. There's not always time once you get to the appointment, especially if, heaven forbid, if you're late or rushed. That way everything is done ahead of time and you can get the most out of your visit time with your provider. So when you get to the appointment, when you go for your visit, there's a couple things you'll need to bring with you. First, you need to bring a list of all the medicines and supplements that you take. It's easy to forget one if you don't write it down, so make sure you have all of them written down and bring that with you. Next, it's also helpful to bring a list of name and phone numbers of your other physician or providers that you see. It's also important to bring your insurance card, copy of your medication records, if the provider that you're visiting with doesn't have access to those already. And of course, don't forget to bring your list of things you need to talk to your doctor about or any forms that you filled out as well. As you plan to go to your doctor's appointment, you may also want to bring a family or friend with you to be able to listen in your appointment with you, with your provider. They can help that way. So if you forget something that the physician had talked to you about, you have someone there that is a resource to help you remember those things. Make sure you can also see and hear your doctor as well while you're at your appointment. So remember to bring any glasses or hearing aids if you need those. Whether you have someone else with you at your appointment or not, it's always a good idea to take notes with you for what your doctor's discussing with you, so that way you're able to reference that back once you get home for either your own questions or questions that your family or friends might have that who didn't attend the appointment with you. When you talk to your doctor, start by choosing 2 or 3 questions or concerns that you want to discuss that are most important to you. Also, be specific about your concerns. Are your symptoms constant? If not, when do you feel them? Is there anything you can do to make your symptom better? Is there anything you can do that makes it worse? Do your symptoms keep you from doing your daily activities? And if there's specific ones, which ones? Your doctor may also ask when your symptoms started. What time of day do they happen? How long do they last? Do they last for a few seconds, or is it all day long? Your doctor may also ask how often they happen, and if they seem like they're getting worse or better over time, and if they keep you from going out and being active. Another thing you want to talk to your doctor about is your diagnosis, specifically if it's a new diagnosis. You may want to ask if there's any tests to confirm your diagnosis. You may also want to ask, what can you expect within the next year, 5 years, 10 years, 15 years in regards to your disease process. You will want to know how your doctor will treat and manage your condition as well. You may want to know how this diagnosis will affect your life long term, or how you can learn more about it. If your doctor prescribes a new medication for you, ask them these questions to make sure that you fully understand everything you can about your new medication. You'll want to know when to expect the medication to start working after you first start taking it. What side effects would you need to watch for? What do you do if you miss a dose of medication by accident? You can also ask, when should you take the medicine? Do you need to take it with a meal, before meals, after meals? You may also want to ask if there's any food or other medications or activities that you should avoid while being on this medication. And then also ask if and when you will need refills, and then how do you go about getting those? So after you leave your doctor's office, you may not remember everything that was discussed. If you have any questions or concerns of anything that they went over or instructions, you can always call the office or send a message if they have a patient portal where that's accessible. A nurse or another staff member will check with the physician or the provider and call you back with an answer. Depending upon your doctor's office, some, like I said, have patient portals where you can also send messages to, or many times you can also call as well. Once you begin a new medication or treatment, be sure to attend your follow-up appointments. These are the opportunities to report back to your provider of how well the medicine and or treatments are going. And if you have any questions or problems between appointments, please reach out. Don't necessarily wait until your next appointment, because many times that can be several months between appointments. So using these tips that we discussed, they can help you prepare for your doctor's appointments. This can help you get your doctor a better chance to take care of you and therefore keep you healthier. So hopefully this was helpful in giving you some guidance for your appointments. And we look forward to seeing you.
With that interview, I saw Joe Klein looking at his watch occasionally. I think he was wondering when he was going to talk and when he was going to be off there. And as I noted, that within the 20 minutes time you heard David Basil talk and others talk, there was very little time for Joe Klein.
But they're not geared up yet for doing kegs and things like that. But he said that they'll be, making the rounds to a lot of establishments and trying to get it put on tap, or in the cooler, or however they want to do it.
The guy who's in charge. I said, yeah, I got a little connection to this. He wasn't even paying attention. He's like, he didn't. I said, yeah. I said, and he's just looking around. I said, yeah. I felt like, well, dude, you wouldn't even have this damn fight to come up with it 29 years ago, because you remember what it used to be called, Big Red. That's what it used to be called. And so a Razorback really isn't red, unless the cartoon one or the animated one is, but a real Razorback is not red. And Tusk has a little bit better mascot feel to it than Big Red. I know it's
the perfect name.
Yeah.
And you're the one that came up with that.
Yeah, I just told Coach, let's get a real Razorback. Remember, because it was a Duroc pig when I was up there, Joe. It was embarrassing. It was a Duroc. It was like a farm pig.
Don't start dropping names like that and not explain it. I'm unwashed mass.
Yeah, it was like an old pig. Duroc is like a farm pig. It's like a big old farm
Why didn't
pig.
you just say farm pig?
Well, I'm sorry.
See,
It's just
he wanted to.
Oh, he
show
wanted to
you.
talk down to me. Would you say similar to Arnold Zippel? See, that I understand.
yeah. Anyway, but that's it. And
Yes.
because of the Stokes family, Keith Stokes, we got a real Razorback in there. We changed his name to Tuss, so appropriate.
I'm looking at
If you want to get Heath in real quick, Josh. Did you want to squeeze in Heath or no?
So far on my podcast, I have not been accused of talking down to anyone. So there, David Basil.